campus at Alcidion, and today I'm just going to cover the technology we have in terms of Miya Precision, which is an open standards real-time platform for doing the kind of things that we talked about earlier but how do you scale that up over multiple programs and multiple scenarios and care settings. Just very briefly, we're an ASX-listed health informatics company originated in Australia. We have presence in the UK, Australia, and New Zealand, and mainly I'm going to cover around Miya Precision, but we also are really good at getting data out and back into different systems. And interoperability is a really core theme of really pulling together the health system as a whole. So the current state that we're dealing with is really that with existing IT systems, they've shown, minimal changes in safety. In fact, even with electronic patient records in the US before COVID, preventable errors in healthcare is still the third leading cause of death. And there's all this variation out there, which is why we need pathways to reduce that so-called unexplained variation. And we're not really engaging consumers that well. And then IT tends to lower productivity for clinicians. And then when, looking at some of the talks following me today, we've got these amazing bits of innovation occurring, but there are some real blockers in the sense that a lot of vendors out there are blocking or locking in data as a strategic advantage, so-called strategic advantage. And I guess it has worked pretty well for many up till now. But the problem is that each innovation spends a lot of effort just getting data and integrating it, or they give up and say, well, we've got our own system here, and that becomes another silo. And as our patients become more complicated and we have to adjust and adapt programs for their preferences and their literacy levels and their technology levels, we need to bring all that data together in a way that is meaningful. So Miya Precision is really designed around improving logistics, safety, improving clinical productivity, and supporting new models of care, which is bringing the data from all different parts of the healthcare system together into an open standards format, which we use FHIR, the Fast Healthcare Interoperability Resources. But it's also about supporting innovation in that others can plug into Miya Precision rather than having to worry about how to get the data out, how to integrate it into clinical workflows, how do they access all the labs or vital signs or whatever it is they need. That becomes part of our sort of proposal, I guess, value proposal, and sort of being able to be a platform for innovation. So what we believe is that we're very much committed to open standards and unlocking the value in existing IT systems, but we also acknowledge that we talked about barriers to consumers and clinicians, but there's also barriers in terms of the IT staff who aren't really haven't got the experience of implementing complex real-time systems and managing AI algorithms, etc. So our platform does all of that, and it's a real-time smart infrastructure. So the way we talk about it is Miya Precision is the core. It has decision support, a whole lot of terminology and ontology, a lot of informatics stuff. It also becomes the FHIR clinical repository, so all the data longitudinally is sitting there. Then we have various modules which people can choose to use. And then we partner with other companies to fill in the gaps. So we are very keen on partnerships and working with other companies to layer on top of the platform and some of those and use the data to be able to contribute to that data to provide that longitudinal record, but then also have access to that data, and we can present all of that out as FHIR APIs, which means that other people can just build apps on top of it. So it's quite a radical change from the, lock in all the data and everything, and the one vendor has to do everything. And the way that works is that we take in data from PAS, say existing best of breed systems, wherever we can get it, and including third-party apps. We also are able to take in prems and proms, device and wearable data, and data from out in GP and community. We put that all together, we clean it up. We have two paths. One's more of a traditional table-based sort of view for reporting, integrated with financial and other resourcing sort of areas, which I won't talk about today so much. The other aspect is Miya Precision, which is FHIR-based, And in part of that is that integrated decision support engine. So what is happening is that every bit of data that occurs anywhere in the health system that flows through My Precision, the decision support engine is looking at it and going, well, what have I got registered with me that it needs to operate on that? In other words, a new pain score comes in, or someone gets admitted, or someone's at home, and for example, the device data comes in. But also it can trigger other applications and other algorithms from other third parties as well. And then we can present that out as FHIR data also. So what does that look like to the clinicians? So what we do is we have what we call clinical operations dashboards, which are really about configuring up systems which really support the model of care. So for example, this is some work we're doing with some customers on, there's some studies out there showing patients coming in with fractured NOFs don't get documented pain relief in the first 24 hours. So this is sort of implementing the national guidelines in a way, helping people understand what's requiring to be done, tracking pain scores, any relevant complexities, automating referrals to, say, diabetic nurses, etc. So it's not your junior most doctors and nurses having to go through heroics just to do the basic plan. So automation is a really key part of what we are talking about, as well as being able to track timers and all that sort of stuff. But also the same technology is used to monitor out of hospital data. So we integrate with devices, patient-entered data, etc. So we can monitor patients right across that population. So what does that look like really? So here's an example of a patient level dashboard, and it's not just view only. If you click on any of this stuff, all the actions are right there. So you can, complete tasks, you can do assessments or update, say, wound statuses or weight bearing, and for certain different cohorts, for example, or range of movements, automate checklists and plans. So the idea, and if you click on that, you have access to all their data, all the observations, all the diagnostic reports. And in fact, we also get all the notes. We also capture notes, but we do real-time natural language processing on these notes as well. So you can see we're picking up clinical concepts, which can also be used for clinical decision support to understand the full complexity of the patient. So what we're really saying is that to create sustainable and scalable models, not just around virtual care, but around any kind of program, we need decision support to be able to detect candidates for different programs, for different pathways, help to automate those pathways, understand when patients are ready for substitution services based on their particular conditions and also their preferences and all their other factors that we need to take in. Ideally, even who's needed, say, for conditioning, preconditioning before theatre, and also when they're in the community, detecting trajectories that may reflect that they're not doing so well and may need interventions. So our view is that how can we draw all that data together and have that in a more centralized, unified platform? And we integrate with a variety of different devices and apps, for example. But a key part is being able to either implement other people's pathways, but also automate those pathways that can go from in the hospital, but back out into the community as well. Finally, the whole idea of decision support is a core around my precision in terms of being able to automate clinical practice. So, for example, with one of our customers, they want to notify when a potential neck of femur admission comes in, say a fall with a fractured, hip pain or whatever, using both natural language and codes. The senior clinician wants to be notified about that, and so they can start to monitor. The junior doctor may be stabilizing them, but the senior doctor can get notified of the X-ray, NOF or no NOF decision, and then make sure that the stabilization plan is being underway, but also then automate all the work that's required to the orthopods, the geriatric orthopedic physicians, whoever else needs to be informed. And we centralize all of that knowledge management as well. So My Precision is a very broad platform based on interoperability, but also really it's trying to be an active participant in healthcare rather than just a passive data store. And of course, we've got lots of metrics. So this is just an example that you can monitor your services and your programs and set up different metrics around that. So our approach in general is about completely agree with the kind of automation and the pathway support. Our approach is different, I believe, to many in health IT, unfortunately, at the moment, in the sense we're open standards, open interoperability. It's an active system, talking about real-time decision support, which we think is a smart assistant for clinicians and ultimately a smart concierge for patients, regardless of what conditions they have, because as we know, unfortunately, patients have multiple comorbidities and are often on multiple programs. And ultimately has that smarts in it to be able to support sophisticated decision support and AI and predictive algorithms, while being able to do all the knowledge management and monitoring those algorithms at scale, which is also a very complex thing to do as we move forward into putting this into production and to manage all this technology in a safe and scalable way. It's a lot to take in, so appreciate that. So it usually takes more than a few 8 or 9 minutes to cover this material, but hopefully it's given you a feel for the kinds of technology. And again, we do have other areas like mobility, where we have full mobile electronic medical records, for example, that bring forward data from multiple sources, including, for example, what do you want to see on your post-op ward round, and that data being pushed to clinicians, including mobile x-rays, etc. So a lot of pieces as part of the puzzle, and lots of ways to interface into clinical workflows and support all the kinds of innovations that are occurring out in the consumer space as well. Thank you.
No, thank you, Malcolm. That was just slightly over, so I'm just a little bit conscious of time there. But I think that was a really, really good presentation. I think if people have questions for Malcolm, if you're able to pop them in the chat, and then any contact details in there, and then pick up at the end of the session, if that's okay. I'll hand over to Rob Lewis from FLX.
Thanks, Sophie. I'll correct you straight away. It's actually Flex, not FLX.
Flex, sorry.
Unfortunately, some other people got
my pronunciation wrong there,
including one of the people on this call, so I won't call Matt out on that one. But anyway, that's by the by. He's smiling. I'm just going to share my screen. I hope you can see it. It's always a bit tricky showing on I think. But you should be able to see a screen now that says Flex Health. Yeah. Cool. I also presented at an event you held earlier this year on the same topic, so I'm going to give it a different emphasis because I know some of the people on the call have heard that before and I don't want to repeat myself. I get bored of listening to myself as well, so I feel really sorry for you guys. So I'm actually going to talk about Flex Health and really what sits at the heart of it, which is the intrinsic biomechanics model that we've developed. And I'm going to explain that to you as we go through the presentation really quickly. Again, I planned this for 10 minutes. I'll try and do it a little bit more quickly. There's not many slides. But fundamentally, what we've done, which is something we believe is, well, it is unique because it's data we've generated on our own. It's different to how other people are addressing digital physiotherapy, is our product, our app has at its heart an intrinsic biomechanics model. And I'll explain what that means in a minute. But basically, we've just digitized that and we're marketing it as the Flex app. And it's a remote digital tool. It's about self-care, musculoskeletal health. Importantly, it's an upstream health approach, and we're preventative. We're focusing on prevention rather than treatment. And we believe that our advanced biomechanics understanding leads to a different approach to standard treatment. So that's just a bit of background blurb. That's just a tiny picture of what the app looks like, but basically you can either treat pain or use the preventative biomechanics model, and that's where our biggest focus is. As I mentioned, Flex uses our proprietary intrinsic biomechanics model. I'll just check that you've seen the slides change, by the way, before I carry on. Please shout if they haven't changed, because I can't see what you can see.
They have, yeah.
Okay, cool, thanks. Not that I'm paranoid or anything. So as I mentioned, Flex uses our proprietary intrinsic biomechanics model. And really what it does is it addresses where people have biomechanical dysfunctions before that leads to any musculoskeletal issue or pain. So as I said, it's a focus on prevention. With the model is actually developed in a 4,000 patient data set, so it's very, very robust in that sense. It actually took 15 years to develop, and we've proven it subsequently in 15 clinical studies. So in total, we have nearly 6,000 patients of data in there, so we have a lot of evidence that sits behind this as well. And fundamentally, the product does three things. It treats musculoskeletal disease and reduces the risk of injury. It can treat pain, and importantly, it can help support healthy movement. So in other words, enable people to have a good quality of life. And at the bottom, just explain what the intrinsic biomechanics model means. basically the model understands the complex relationship between the osseous, neural and myofascial systems and our genetics, and effectively assesses where we have biomechanical dysfunctions to improve our musculoskeletal health. And biomechanical dysfunctions can occur in any part of the body and can cause ascending or descending problems. So, for example, you may have something wrong with your shoulder that causes a problem with your knee. That's a descending problem. You may have something wrong with your hip that's causing something wrong with your neck. That's an ascending problem. So effectively, our model can understand how biomechanics relates in this, and we figured out the best ways to fix it using physical therapy. So that's just a bit of background. Now, in terms of what that means to people, I'm just going to share with you a couple of case studies. So this is actually quite a young girl who had knee pain, and she had persistent knee pain, couldn't run, went to see a GP. The GP was unable to find anything wrong with her, and basically discharged her. We treated her with Flex, and we found out she had a left leg length discrepancy, which is a really hard thing to say. And you may be able to see on that picture, you can see her left ankle is slightly below her right ankle. And what that was causing her to do was to compensate. And here's a picture of how she compensated. We actually found using Flex that she had pelvic biomechanical dysfunction, and that was causing her to bend her left knee to compensate for that dysfunction. Now, we used Flex to intervene with this, and within 7 days, she's back running and pain-free. And you can see here that the left discrepancy has been addressed, and she's standing normally. That's one example of a patient we've treated. I'm just going to move on to another one quickly here. This girl presented with a hip spasm. She's actually an elite athlete, a rower, and I'm just going to play a video so you can see what's wrong with her. As you can see, if you're a rower, you can see her left knee is protruding out to the left as she's rowing, quite noisily. And what we found using the intrinsic biomechanics model was she had muscle spasm in her hip, she had scoliosis, and that was causing loading of the knee, and consequently was causing her problems with her biomechanics, but also importantly for her, it was causing her to not to be able to row as quickly. We were able to correct this with Flex, and as you can see from this video, if you compare her previous function, you can see her legs are nice and straight here. So that was good for her because it allowed her to row more quickly. But it also reduced her biomechanical dysfunctions, which would have eventually led to potentially quite serious pain and other problems. And then this is the last thing I'm going to say. We've actually got quite a lot of evidence, as I mentioned before, so I'm just checking on a few of the pieces of data here. So in one of our key studies, we tested in the South Yorkshire Police Force, and we were able to achieve a reduction in musculoskeletal disease of 64%. That actually scaled to them as a £1.4 million a year saving. We also did a study in the Dorset Fire and Rescue Service, and we were able to reduce absenteeism by 52%. And we also done some work in the NHS, and in that study we showed that for every £1 spent on the intervention, they've saved £16 in primary care. And I'm going to leave it at that because that's, as I said, a relatively succinct number of slides, so hopefully gives you a bit of time back, but obviously if there are any questions, I'll be very happy to answer them.
Brilliant, thank you very much. I think again, if we pop any queries in the chat, if that's okay, and then come back to them at the end, just to allow everybody equal time for presentations and so on. Tom, you are there. I just emailed you because I couldn't see you. But yeah, I will hand over to Tom Gorsden now at Patient Knows Best. Sorry, if you're able to share your slides there.
So hopefully you should be able to see my slides across the top. So Patients Know Best home slide. Has that come across?
Yes. Yes.
Perfect. Brilliant. Well, I will follow suit and whittle through my slides just to give you a bit of background information into who we are, what we do at Patients Know Best, and then talk through some of the use cases and the scenarios in which PKB is used. So PKB, we're a patient-held record, a personal health record, a patient portal. We go by many different labels and brands, unfortunately. The idea behind the platform is that we put the patient at the centre of the care that they receive. So as we've heard earlier from Andrew Bennett, there's a a whole host of different services and settings involved in the care of patients, particularly across the MSK pathway. So those within primary care, acute services, mental health, and the third sector. So this is why PKB exists, to plant the patient in the centre, integrate information from across those health and care services, and provide the patient with a single place to access that information. Not only can they access it, they can share this information with whomever else needs any level of access, including those carers, family members, other care collaborators who are often left out of accessing any information. And then the patient's also prompted to contribute a whole wealth of information into the platform. So whether that be directly through symptom tracking, whether that be questionnaire responses, or via integrated apps, devices and wearables. So at this moment, you've got that kind of consolidated record between professionally generated information, patient-generated information held and integrated around the patient. And then on top of that, we add educational materials, so allowing the patient to access those self-management resources to provide that clearer understanding of their own health and well-being. So just to give you a bit of an idea in terms of the size and the scale of what we do, so we're the largest PHR provider across the UK. We have over 700,000 registered patients, so just over 1% of the UK utilising the platform. And within the Yorkshire and Humber patch, we're working with York and Scarborough teaching hospitals, Hull University teaching hospitals, Mid Yorkshire hospitals on a trust-wide basis, but also working with Northern Lincolnshire and Goole within their cardiology services, and the entirety of the region's renal services as part of PKB's UK-wide replatforming of renal patient view. So just to give you an idea of some of those digital tools that are available, I mentioned that ability for patients to have digital interactions with their health and care services via the messaging capability, that ability for remote monitoring to take place, whether that be through questionnaires, whether that be the integration with apps, devices, wearables, or the other recording of measurements. I also mentioned that ability for patients to access information. So that, again, spanning those numerous health and care services, includes information related to scans, for example, appointment data, integrated test results, all feeding and flowing into the platform. Then on top of that, those educational materials. So whether that be collaborative care planning to support that self-management, or accessing a verified and validated resource library for patients. So I just wanted to echo Graham Walsh's comments earlier as well, in terms of ensuring that everything's really easy to use, really simple to access, and that being the kind of key to success. So as part and parcel of the work that we do at PKB, we've actually integrated the bulk of our solution into the NHS app. So as a patient, I only I've got a single front door to accessing all the tools, all of the capabilities I need to manage my care, whether that be responding to a questionnaire such as the health assessment questionnaire that I'll be touching on to support rheumatoid arthritis, whether that be adding a device to automatically track my activity, again to support with my recovery, or that mechanism by which I can access my care planning information to set my goals and access the latest materials that I need to manage my care. On top of that, patients can actually access the platform and register using NHS login. So again, a secure, verified mechanism by which patients can gather access. So now I just wanted to touch upon what does this look like in use. So again, here's a health assessment questionnaire, or rather a rather small screenshot of the entirety of that questionnaire to support patients with rheumatoid arthritis. So actually, how can we capture this information without making that patient go in for that face-to-face interaction? How can we remotely monitor and track that progression of that patient's condition, whether that be through multiple choice options, radio buttons, free text entries, again, anything that we can do to support virtual interactions and that remote monitoring. I also wanted to share a piece of work that we've done in Derby to support the Achilles tendon pathway. So as soon as a patient appears in their kind of ED or minor injuries, as soon as they're referred to their initial outpatient appointment, the patient is recruited and invited to join the PKB platform. As soon as they're there, they can access all of the materials that they need at all of the stages that they need throughout their recovery. So again, enabling patients to understand what's going to happen in terms of their recovery, what they should expect, whether that be through embedded videos, the contact details they need for individuals within the services, whether that be images and supporting information or useful resources and links. So at every point in that patient's recovery, they know what does good look like, what should I be aspiring to, and also have the routes to reach back into the service if they're needing any further advice, guidance and support. And then the final slide I wanted to touch on is a bit of a shameless plug. So as well as being part of the business development team at PKB, I'm also our lead for sustainability. And I know throughout the kind of conversations earlier on today, we've touched upon not only why doing something differently within the MSK pathway is better for patients in terms of improving the care they receive and better for the services that are providing that care in terms of freeing up capacity, but also the knock-on impact that has in terms of the environmental footprint associated with the delivery of care. So where we're able to prevent those unnecessary face-to-face appointments and associated travel, where we're able to intervene earlier in a patient's recovery, identifying that kind of early deterioration, enabling much more carbon light interventions to take place ahead of, as I say, unnecessary surgical cases or inpatient stays. So this is just a couple of case studies associated with the carbon savings generated from a deployment of PKB. So I'll leave it at that, but again, I'm happy to answer queries or questions in the chat, and I'll pass it back to you, Sophie.
Thank you, Tom. That's a really good overview, and I think the carbon savings are really pertinent. Particularly, we've seen that being mentioned a lot more and increasingly in tender documents and so on as well. So that's a really important point there. I think, like with the other presentations, if you're able to pop in your contact details, Tom, in the chat, then people can get in contact with you directly, or pop any questions in the chat, and then we'll do a roundup of questions at the end, if that's okay. We have in healthcare / health call up next. Rob, I'd imagine that presentation's from you. I know there was a few names down, but I can see you. So
it is. Hi everybody. Good afternoon. If I just get set, that should be there. Can everybody see my screen?
We can, yes.
Yeah, great. Good afternoon. I'll keep it very simple and speedy. We are in healthcare and based in Harrogate within Yorkshire Humber HSN region. We have, in the case of today, partnered with Health Call, who regularly deliver services with us, and this obviously being relevant, the MSK pathway. If I just move on. Amongst other things, we've developed things like our digital outpatient patient portal, which is quite a mouthful, but Health Call will be rolling that out throughout the UK. Very exciting news again. Right, okay, what makes in healthcare unique? So a single platform across every clinical setting. Importantly, I think I want to touch on this, NHS approved. We have over 1 million users using our services, and there are now 100 pathways in use. Particularly in the case of collaboration, which we're talking about today, new services can be built and rolled out very quickly because we've already developed those within that relationship with our delivery partner. We're confident that we're digitally inclusive, and again, interoperability, integration, and our link straight into the spine makes it very easy for us and Health Call to get the service across as quickly as possible. Why do our partnerships matter? Well, again, as I've just mentioned, they've helped us develop services that we've been rolling out throughout the UK. We have another partner in the region, CHCP, but in the case of Health Call, we have more than one service live nationally. So without further ado, I will actually hand over to Health Call, who will run through. So I'll introduce you to Nicola Emery, who will go through what the services meant and why and how we've rolled this out.
Hi, I'm Nicola Emery. I'm professional lead for adult physio, and we've been doing quite a bit of work with Health Call, particularly around self-referral, patient feedback and proms as well. So what we looked at was self-referral form into the MSK service. So we previously used paper format, or they could access a Word document and complete it and email it to us. On this, we got inconsistent information provided by the patient, so we couldn't triage them correctly to the right person at the right time. Patients also had the cost of posting the paper self-referrals to ourselves, and there was also issues with time taken to process. So patients would send in a paper version of the self-referral. This would need to be scanned, then it would need to go into our System 1 portal, and then we would need to triage it. So what we looked at, next slide please, was a solution to aid the self-referral process for patients. So what we did was we designed a self-referral form which was to be completed by the patient all digitally. It was hosted on our website. So currently we have a link on our CDDFT page, and also the GP practices have a QR code where patients can access it straight through. We'll have certain fields that have to be completed by patients. There's a lot of them are the tick boxes, and we also have some free text boxes. So we make sure that we get the correct information. It can also, because it links to the NHS spine, it picks up the patient, but it also picks up the patient if they're not in our CCG and covered by our service. If it highlights that a patient is not within our service area, then it will direct the patient or signpost them to their service that is appropriate for them. Because it comes in straight into email, into our central appointments, that can just be saved as a document and then transferred straight into our clinical notes for triage. And the patient, as soon as it's submitted, the patient gets an email reply, gets a completed submitted form, so the patient knows that we've actually received it, which was an issue that we had before with referrals going missing. Next slide. So the benefits that we've noted to date are the patients can obviously submit it on a device of their choice. So they can use the phone, they can use the laptop, they can use the iPads. It obviously removes the postal cost for patients to return the form for us. It makes sure that the submission of the self-referral is more timely and can be done at that point. We also have noticed that we get better and more consistent data quality, which means that we can make the triage process much more effective. It integrates with our existing EPR system that we use. And it reduces the delays in care because of the timely submission. But the biggest benefit that we found is the patient's aware that it's been submitted, they know if they're within our service, and the admin processes is so much quicker. So the triage and the access into the service is much quicker. Next slide. What we've also found is obviously that this has an impact greatly on primary care services. So a lot of the GPs now, especially post-COVID and during COVID, actually just email or they actually text the patient our self-referral information. So it's actually saved a lot of GP appointments and they come to us as a first line now for treatment. So that's been a significant amount of saving on the GP's time as well. Next slide.
Right, I think this is over to me. So my name's Catherine McShane. I am actually a dietitian, so nothing really to do with MSK, but I work at CDDFT and I also work for Health Call. And it's really just a brief overview about Health Call, that we're a unique NHS-owned company. So we've got 7 of our regional NHS Foundation trusts that are shareholders within that. And we operate within the primarily within the Northeast, but we will also supply our pathways and products outside of the Northeast and across the country. Everything that we do is designed by healthcare professionals, so it's in response to problems such as Nick's described around getting inaccurate or inefficient information when to be able to triage the referrals, that we came up with a solution with their team as to how we could improve that and make that better system for all involved. So whether that's the patients, the admin staff and the physios that are then triaging that information. And then it's around that share and spread. So the idea being that we do that once and then we can replicate that and it can be shared and spread across the region and outside a region with that. using any of the services and pathways that we've got built. So they can be ideally picked off the shelf and used, but we can then localize them for the other organisations that need to use them for that. So yeah, that's that. Thank you.
Thank you. Back over to you, Sophie.
Thank you. That was a really good triple act there and gave a really good overview. I like the idea that you're owned by NHS stakeholders as well. I think that's a real positive there. I think again, if you're able to pop your details into the chat, we will be sharing information after the event. There'll be a full pack of information going out with contact details and so on, and we'll use the end of this session for questions as well. I think next up we have Matt Booth from PhysioBuddy to talk about their application as well. So Matt, if you're able to share your screen and your slides, that'd be great. Thank you.
Can you all see that?
We can do, yes. Yep.
Yes, great.
Yep. So I'm Matt from PhysioBuddy. A little bit about myself. So I am still a treating clinician. So I'm a physiotherapist. Have been now for 10 years. Have a very good understanding of kind of the importance of clinician time, expertise of the clinician, expertise of the departments that we've been working with, and the role that the allied health professional have to play within protocols, MSK, treatment, essentially. So PhysioBuddy was born out of a team of physios who kind of wanted to improve and streamline MSK services within the NHS and further afield. So it's very much a passion project between ourselves. We wanted a really good user journey for the patient, really simple, really effective. But we very much built the system with the clinician in mind to reduce time and kind of everything that all the other clinicians have been talking about today, reducing resource and empowering the patient. Essentially, that is day in, day out what I do. When I treat, my aim is to make myself redundant. Any good physio should do that. The sole aim of a physiotherapist should be to empower the patient to rehabilitate themselves. Essentially why we came up with the tagline, "Take your therapy home." So what do we do? So we engage with trusts, hospitals, ICSs, and we collaborate. That's our buzzwords. We don't believe in a one-size-fits-all model. We don't think it works. We believe in collaboration. We understand the roles of pathways, hospital pathways, and the good work that the physiotherapists are already doing within the trusts. We don't want to come in and tell them how to do their work. We want to work with them and improve the multimedia aspect of their already established pathways, triage systems to streamline it and make them better. We have the ability to monitor the patient within the system using a chat functionality, guided self-help videos, FAQs. We're just looking at some further progressions around more well-being aspects of the system. But again, that's all in line with this collaborative effort with NHS trusts and hospitals. For the patient then, like I said, we want to empower the patient. We want to put them in control of their rehab, their prevention, their prehabilitation. We aim to reduce the amount of face-to-face appointments or telehealth appointments, and reduce the associated travel time, the carbon footprint, and kind of set ourselves in line with the greener NHS initiative. Improve discharge rates, and when I talk about that, we want to paint a picture of that patient for the clinician, so know exactly where that patient is moving towards once they are discharged. I see day in, day out, I might discharge a patient for a shoulder injury, but then they might readmit themselves 6 weeks later with a knee injury, and we need to get that patient. It's naive to think that we are rehabilitating one injury for the patient. We are trying to change mindset, change perception of MSK injuries as a whole throughout the NHS, and with that, improve quality of life, and then looking at a quicker return to work and reducing that financial burden. So the allied health professional, so we're working with physiotherapists, OTs, dietitians, and again, we have created a very simple system that streamlines their work. It's very little additional work for the physio. They can track the patient, or they can leave them alone. Again, we can be flexible on resource and costs for the trust. But ultimately, the main aim for this is to reduce the complexity of kind of tracking a patient, but also in terms of complexity, for those more pathway and protocol driven rehabilitation cases, what that then allows the physio to do is it free up their time for more complex cases. And then the trust, we aim to reduce face-to-face visits, travel, care miles, reduce DNAs, improve patient adherence to physiotherapy, and in line with kind of everything that this post-COVID world, this system wasn't built with kind of COVID in mind, but it's kind of obviously sits in line with that. So we have a dashboard. So we have an allied health professional dashboard. That's where you can sign patients up. It's a really simple, effective, quick solution. And then that then tracks the patient. We use a traffic light system to monitor where the patient is at on their journey. But ultimately, it's a very simple system to use. And the patient's journey. So again, we use a tier or a ring-based system. So their goals are very attainable and achievable. If you're looking at a total hip or total knee rehabilitation, that's 6 months of rehabilitation. The goal for everybody is to try and make that patient adhere to rehabilitation. Often patients think that, particularly for complex operations like hips and knees, that it is the operation is the final point, but we all know that it's the point past that is the important part. And then we have patient feedback sessions, so we can create our own reporting metrics within the system to understand where the patient is at, to change and amend programs very quickly and simply, and to essentially keep that patient engaged with the system. And then lastly, we've developed quite a lot over the last sort of 6 to 9 months, but we've been supported by another AHSN network down in Kent and Surrey and Sussex. And we're actually going to be one of the featured event stalls at the HET event down on 28th and 29th September. So we're looking forward to that. We've been supported by a couple of AHSNs for health economic reporting. We've aligned ourselves with other medtech companies that can deliver collaborative, innovative MSK systems, and that's kind of led to this build up and accumulation of sites now. So we're now working and workshopping with 8 different trusts and organisations throughout the NHS as a whole. So yeah, thank you.
Brand, thank you very much, Matt. That was a really good, clear presentation around some of the great work that you're doing in the region as well. So again, if you want to pop in your contact details in the chat, and then we'll do questions at the end. Harriet, over to you for Be Brawn, if that's okay.
Yeah, no problem.
And thank you very much.
And I've just realised I'm not sharing with sound, so I'll share again. Wait a second. I wish Microsoft had a way of adding it. So much better, wouldn't it?
Yeah, we would, yeah.
Okay, good afternoon, everybody. My name's Harriet Book, and I'm a Strategic Partnership Manager at Be Brawn Medical. We're a medtech organisation, and we have a global footprint in 64 subsidiaries around the world. That said, in the UK, we're a standalone organisation, and we stand on our own 2 feet. So our innovation involves wearable technology, which Graham Walsh has very kindly given most of it away during his talk. So I'll skim through our tech. Essentially, we embarked on this journey back in 2015 when the GIRF report was first published. And it was clear for us as an implant provider for hip and knee replacements, offering just hips and knees, pieces of metal, wasn't enough within the NHS. They needed technology that would help achieve a lot of the targets that had been set for them. So we looked at the standard orthopaedic pathway back in 2015 and 16 and the touch points that the patient faced. So this is the very simplified version of the orthopaedic pathway and the most direct route to surgery. So if a patient steps on each one of these what I like to call the NHS roundabout, they hop on and off. Each one comes at a considerable cost, and the average cost from the first GP referral right the way through to the follow-up is £7,000 for a patient as the most direct route. So we thought, how could we innovate this? How could we help hospitals achieve their targets? And of course, it was very obvious to us back then, digital would play a key part of that. That said, the market wasn't ready for it in 2016. Fast forward with COVID, now we are, and the NHS has taken on a lot of digital innovations, making things a lot easier to get spread and adoption of technology. So the tech involves a wearable range of motion sensor that we give to all hip and knee replacement patients that are suitable to use the device. They attach the sensor on the leg and they perform daily range of motion tests. After they perform their test, it will prompt them to do some physiotherapy exercises that have been set by the therapist, and then we can monitor their progress remotely. So the aim is really to give this to the patient in the pre-op phase, and monitor, how well their leg is moving. They'll continue with the wearable sensor right the way through to their day of surgery, and we'll be able to identify those patients that are likely to be compliant or incompliant and that might need a little bit more care or a little bit more contact following their surgery. So we used this technology at Caldervale and Huddersfield, and we saw a saving of about £1,100 per patient net after paying for the devices, etc. And this was the average saving that we made per patient. So the green dots within this pathway are showing you at which touch point the tech is used or where it's best placed. So clearly we can see here that in the pre-op phase and the post-op phase, we can use the data that we collect to keep an eye on those patients. So I'll give you a little demo of the technology. This is just a screen record of my iPad while I'm using the app. And this is what a patient would see. It's available on Apple and Android. The wearable sensor works on Bluetooth technology. They simply shake the sensor to activate it. A blue light will come on and it automatically connects. And it will tell the patient what the battery life is of it. Following that, they can press the video icon and it will demonstrate to them how to perform their test. So we have several tests for the knee and several for the hip as well. So it's used for both hip and knee replacement surgery. For this test, the sensor can be applied anywhere between the lateral malleolus and the knee itself. And then once it's in position, we will then calibrate it to make sure the patient has it on the right way. And then they can start performing their range of motion test. Target lines appear. We have an extension target and a flexion target. So the idea is we're wanting patients to surpass that target each time they perform a test. There's an algorithm built within the software. Every 3 times they beat those target lines, they will get a little bit harder. So the tech, so the range of motion improvement improves at the rate of the patient's improvement. So it's very patient-led. They have the option of adding additional pain throughout their range of motion here. So you can see those green diamonds on the screen. That's the patient pressing the pain button, and it's telling us at what point throughout the range they're feeling added pain. And the avatar, as you can see right now, will mimic whatever the leg will do. Once they've done the test, we ask them to log their pain score for the day, and then these are the videos that will play following surgery. We have a library that can be interchanged by the hospital, and they can be changed at any point. So we might give them some exercises pre-operatively, post-operatively, we might want to change those exercises and give them something a little bit more challenging or a bit easier. When they've done that, they can view their stats. That will tell them where their range of motion was for today. They can compare previous days to current. And if they wanted, they could use it as an activity tracker by keeping it in their pocket. Then there's the ability to keep in contact with a physiotherapist via the messaging function. And that's a two-way communication with the hospital. The moment they exit their application, all of the data, their test data, is sent to the clinician dashboard where the physiotherapist can analyse where their patients are within their rehabilitation journey. They'll have a list of alerts that will appear on the screen. So we've got calendars. They're your naughty patients. They've not been doing their exercises. That will trigger a calendar. The warning triangles are patients that are struggling with their range of motion or they're surpassing it by a significant amount. We might want to look into those and see why that is. And the envelope's quite obvious. Then the patients have sent you a message. So it allows the clinicians to decide which patient they want to look at first. If we delve into that patient data a bit deeper, this is actually real patient data that I've taken from Calderdale. You can see preoperatively, they were very compliant with their exercises. Post-surgery, range of motion drops, as to be expected with swelling and stiffness. But then you can see over the course of the week to 3 weeks, recovery, they're back up to where they were before surgery. And the physio can see all sorts of data from exact flexion data, extension data. Was there any pain? What percentage improvement have they had? So it really provides a bit of depth behind that range of motion. So I'll brush over the real world evidence that we did at Calderdale. We looked at just over 20 patients. We saw nearly a 90% compliance of their exercises of at least once a day. And this was over the period of a 6-week follow up with the patients. So very, very compliant, of which 33% of the patients did their exercises at least 3 times a day. Some did more. So it was really reassuring for us to see that from patients. There was a significant length of stay reduction, as you would expect with a day case knee replacement pathway. And we've seen over a 44% reduction in post-op follow-ups, which has significantly reduced, following COVID as well. The patient feedback has been extremely positive with the device there. They're very keen on using the technology. Thought it was easy to download, easy to use, and happy to contact physiotherapists for it. We're proud to say, as part of the partnership, we attracted some awards back in 2019, which reassures us that we're on the right lines with this technology, and we're very keen to connect with other medtech innovations that have pieces of technology like this or that could work alongside ours. We're already in talks with some other companies in how we can create some synergy between our tech and innovate within the NHS. So please do connect with me on LinkedIn or Twitter. I'd be very happy to speak to you or contact me directly on email. Thank you very much. If you have any questions, I think it's onto the chat, is it not?
Thank you, Harriet. That was great. There's some really useful health economic data there as well, which I think with a lot of the solutions that we've seen today, the same savings and the same, as to say, that roundabout of the pathway. A lot of savings could be applied with the different technologies that each of you are implementing there. So yeah, if we do pop contact details in there, and if people can keep posting questions in the chat as well, we'll run over those just at the end of the session. And I'll hand over to Gary from Apparito. Thank you, Gary.
Thanks very much. I'll just bring my screen up. And then... Perfect. Thanks. Hopefully you can see my screen.
We can, yes.
Yeah, perfect. Yeah, so thanks very much for all the presentations previously. It's some really kind of innovative technology going on. So I'm Gary McNamara. I work as the head of academic partnerships at Apparito. My background is primarily in defence rehabilitation. So I did 15 years in the military, finishing off at Headley Court, working in the rehabilitation setting. So I kind of understand where that's coming from as well. Apparito is probably one of the companies that Pete mentioned previously where we don't really specialise in MSK. However, we do have an offering that could definitely benefit the MSK pathway. We're a medical tech company based in Wrexham, and we essentially specialise in capturing patient-generated data. We've done this across kind of the rare disease community, paediatric space, epilepsy, Parkinson's, and a variety of different disease areas and therapeutic areas. We are an award-winning kind of med tech company. We won the Digital Health Innovators of the Year last year, and also the Best Patient Remote Monitoring Solution for our Atom 5 technology deployed within the rare disease space. So I kind of wanted to touch on a little bit on our grant experience and how we've worked within these kind of grant calls before previously. So we have a number of grant calls that are ongoing and still live at the moment, including 2 large NIHR ones, both designed around long COVID. So clearly, again, not really an MSK pathway, but what these are, and I kind of give you a little bit of an explanation now, really configurable patient-facing applications alongside a clinical dashboard that we've designed with the clinical teams at University of Birmingham, University of Cambridge, Liverpool University and Cambridge University hospitals. We've built out a really bespoke application and dashboard for them so that they can actually monitor symptoms, start to provide some objective assessments through the smartphone app,
and also start to get real-time data back to the clinician dashboard whenever they want it, essentially. The other one that we have currently ongoing with regards to grants is an NHS X grant that we had as part of the COVID response with oncology patients up in North Wales. This has now been moved forward into a virtual cancer ward, but essentially what we were trying to do was keep patients out of the hospital setting through really bespoke remote monitoring. On this one, we were utilising some wearable technology to understand sleep patterns, movement patterns, and start to look at the disease pathway, whether that was a regression in it or whether they were progressing through the disease pathway really quickly and we wanted to bring them back into the clinical setting. So that's a little bit of an overview of our grant experience within the UK. So why rehabilitation? Why kind of Interoperability stepping in to say this? Well, ultimately, the Atom5 technology that we have is disease and language agnostic, meaning we can work in any disease area across any language and anywhere in the world. And one of these things that we kind of really pride ourselves on is pushing out really patient-centric technology to ensure that we are capturing as much relevant data as possible, providing it back to the clinician, but ultimately making the patient experience much better. So the way that we do this is a fully bespoke iOS and Android smartphone app. And this is where we build out patient-related outcome measures, our video technology, whatever is needed to ensure that we're capturing the most amount of data that's going to provide the biggest insight to the clinicians. We build this to the kind of the vision of a clinician. So we have a mix of functions of toggle switches, sliding scales. We've done validated questionnaires. We've done non-validated questionnaires. We've started to validate our video technology now. We have partnerships at the moment with Alder Hey Children's Hospital, where we're really developing this into the paediatric space, and also a really good partnership with University of Birmingham, where we've been working with patient groups such as traumatic brain injuries, clearly with movement patterns, neurology diseases, and also some of the COVID patients that are struggling getting upstairs, getting out of bed and the likes. What we can do is we can mix this with a mix of active and passive data collection. So we can actually just use the wearable devices to continually capture the data if we don't want the patient to be kind of put out at all. Or we can also actually get the passive stuff as well. The video and voice capture technology, I'm not sure if this is a video, it is. What we're able to do with our technology, and this is developed from our Parkinson's trials, is we're able to start to provide objective markers on assessments such as the time up and go, gait analysis, balance assessments, and the like. So what we can do is we can provide objective markers on anything such as knee flexion extension, hip alignment, arm swing, whatever we need to look at, we can start to provide them back as objective measurements. What we found with these assessments previously, particularly the time up and go assessment, was it was a very subjective test where it was literally the patient would stand up out of the chair, walk around a cone, sit back down, and the time would be the objective marker there. Within the Parkinson's disease community and looking into kind of rehabilitation, what we noticed was the more data we could capture here, we could start to analyse the trip hazard, kind of how much they were going down that alignment, and whether they were going to start to look at trips and falls. All the kind of muscle and joint alignments, were they still working as we wanted, and we can start to notice clinical deterioration early and provide that back instantly to the clinician. We also have partnerships with Garmin and Withing, so we're able to provide wearable devices, which just allows us to capture a more holistic approach to all the kind of patient data we're capturing. So once we've captured this data, where does it go? It goes into the clinician dashboard. So the clinician dashboard is where all the data is housed. As you can see there on the left-hand side, we color code it, allowing an easy and quick triage system for any of the clinicians. They can go on there and click on it, depending on parameters for the disease pathway or the rehab pathway. We provide a fully decentralized approach or a hybrid approach, because we know some clinicians like to see patients in the clinical setting, and also some are happy with patients being out of it completely. So we can provide a patient onboarding and e-consent. We also have DocuSign with that to kind of push up the compliance levels and to go in for ethics submissions and things like that. So we can provide that through the patient-facing application as well. The clinical portal, it allows a one-stop shop for telemedicine functionality, so clinicians can provide video calls on there, they can send out videos, pictures, information sheets, whatever they need to send out instantly to a patient's phone. And also the dashboard, you know, is used as a kind of a view for an individual. So we have the individual aspect of that. When we click into it, we can see patient-related outcome measures, wearable data, medication adherence, whatever it needs to be, we can capture that in there. So just wanted to touch on a couple of our unique offerings at what I mentioned before, and looking at the kind of the future of assessing disease progression or rehab progression, I suppose, as we're looking at it now. And this is part of the VTUG, so the virtual time up and go assessment that we had. So what we're able to do from a home-based assessment area is we're able to ask the patient in a home setting where they're comfortable, in front of a carer, in front of their parents, rather than bringing them into the clinical setting, asking them to go through a squat pattern and instantly sweating. I'm sweating now thinking about it. We can put them in a comfortable setting in the home one and start to really look at some really valuable data and providing it back. The way that we do it, this software locates points on the body. So what we have is 25 points on the body and 70 points on a face. So we can start to provide confidence values onto that and look at things such as smoothness of movement and erratic patterning. And then we can provide it back instantly in the graphs on the clinical dashboard. The final one is our Sarah Home kind of offering. So this is another module that we developed. We developed this with the DZNE, so a neurodegenerative university over in Germany. And this is based on the scale and rating for ataxia. So previously 8 assessments that they used to do in clinic, including kind of balance, gait, nose to finger to nose and the likes. What we're able to do now is we were able to digitalize 5 of them assessments and look at the correlation, which really highly correlated. And we can provide this through the smartphone app as well. What this also allowed was the clinician to actually have more time in the clinical setting where they can sit down, they can look at it in their own time. They have the objective markers, they have all the data they need to look at that. And like I say there at the bottom, although it was developed to assess ataxia, things such as gait analysis and the balance, the domains like that can go across into any kind of rehab pathway and any disease area, really. And then finally, where to find us. If you want to look either myself or Aparito up on LinkedIn, or have a look at our website, and also I'll pop my details in there. But thanks very much for having us.
Thanks very much, Gary. That was a really good presentation. I think that really illustrates the benefit there of if you have a pathway developed in one clinical area or a technology that can be adapted to others. There's a real benefit there in having that almost that generability, sorry, but then being able to adapt your technology to multiple pathways. So that was a really good presentation. Thank you. We do have some time before the main session wraps up to be able to go through some questions. Does anybody have any questions that they want to raise with any of the speakers from this session at all? Everyone seems to be quiet, either quiet or shy. If you wanted to pop any questions in the chat or make those introductions individually with one another through contact details and so on, you're more than welcome to do that, obviously, with people having shared their details. There will be a wrap up in the finals in the main session that should be starting at about 5 to. If anybody needs the link to get back into that room, I will just pop that back into the chat. If you have kept it on hold, it should be there. And I will just stop recording this as well.